So good afternoon, everyone. My name is Cassidy Napier, and I am a second-year medical student at the University of Louisville School of Medicine. I'll be presenting today on behalf of the Louisville team and Dr. Raj. And the case we'll be discussing is a severe presentation of multiple infantile hepatic hemangiomas that required ECMO. So this patient had a history of prematurity, was born at 24 weeks estimated gestational age with associated intraventricular hemorrhage, bronchopulmonary dysplasia, retinopathy of prematurity, and hemoglobin SC disease. The patient had been admitted 3 months prior to the severe presentation we'll be discussing today with acute chest syndrome and received a transfusion of packed red blood cells during that admission. An ultrasound of the abdomen at that time, which is shown on this slide, incidentally demonstrated a heterogeneous nodular appearance of the liver, and due to this finding, repeat imaging was planned in 3 months. On May the 3rd, at 9 months of age, the patient presented to the ED after 3 episodes of vomiting with poor PO intake and fatigue for the last 2 weeks. Patient was afebrile with stable vitals, and abdominal X-ray showed possible hepatosplenomegaly with increased stool burden. An abdominal ultrasound was ordered for further evaluation and showed a liver of up to 9.6 centimeters with numerous lesions that were concerning for metastatic disease. On physical edge was 3 to 4 centimeters below the costal margin, and 3 hemangioma-like skin lesions were noted. The patient was admitted to the hem-onc service at that time for concern of malignancy. A CT was performed for further evaluation and demonstrated findings most consistent with infantile hepatic hemangiomas. While most are asymptomatic, they can present with severe complications such as congestive heart failure, hypothyroidism, and abdominal compartment syndrome. The highest rate of mortality is seen in diffuse hepatic hemangiomas like those demonstrated in this CT of our patient. Our patient was started on solumedrol as well as propranolol at the time of imaging for treatment of the hemangiomas. Soon after admission, the patient became unstable with persistent hypoxia and delayed capillary refill. Seizure-like activity was noted with severe hypoxia that required intubation and transfer to the PICU for management. An echo revealed severe pulmonary hypertension with right ventricular pressures equal to systemic pressures, as well as right to left flow across the PFO. There was also evidence of right ventricular hypertrophy and left atrial and pulmonary artery dilation, suggesting a long-standing process. Overnight, the patient developed a pulmonary hypertensive crisis that was unmanageable with sedation and suctioning and eventually led to a bradycardic arrest. Patient was cannulated to ECMO, where she was managed for 13 days. They had continued pulmonary hypertension in the setting of ECMO, as well as after extubation and transfer to nasal cannula, which was managed by cardiology with sildenafil. While in the PICU, the patient received multiple packed red blood cells, platelet, and cryoprecipitate transfusions. The hemoglobin electrophoresis remained with a hemoglobin S of less than 30%. The patient continued on solumedrol throughout the PICU admission and was slowly weaned and transitioned to Orapred while on ECMO. She continued propranolol for treatment of the hemangiomas, which achieved optimal dosing prior to discharge. Given the seizure-like activity that developed prior to the intubation, the patient was followed by neurology. She underwent EEG, which was unremarkable, but MRI of the brain raised concern for a possible thrombosis, which was confirmed with a venogram as a right sigmoid sinus thrombosis and bilateral convexity subdural hematomas. The hematomas were felt to be related to parenchymal volume loss, given the increased sulcal and ventricular prominence on MRI. The patient was managed on Lovenox for thrombosis, and the hematomas were closely monitored by neurosurgery. The patient maintained stable head circumference, and the subdural hematomas had decreased in size prior to hospital discharge on June 7th. An MRI of the abdomen was obtained prior to discharge as well, and is shown above. The multiple hemangiomas remained relatively stable since the initial CT that was done on day 1 of the patient's 35-day admission. The patient underwent a follow-up MRI 3 months after initial imaging, demonstrating extensive hemangiomas that had overall decreased in size in comparison to the baseline study. The overall liver length had decreased minimally, but remained slightly enlarged, as seen above. Following discharge for the severe complication, the patient has been hospitalized multiple times for acute chest syndrome, including 6 days in December, 4 days in March, and most recently 7 days in April. During the most recent admission, the patient developed acute hypoxic respiratory failure, but did not require intubation and was managed with a high-flow nasal cannula. There was evidence of ongoing pulmonary hypertension, and an echocardiogram at that time demonstrated trivial TR jet velocity, mild right atrial enlargement, and moderate right ventricle enlargement. Trivial PR jet velocity was also noted, and the study was inadequate for measure of the right ventricular pressure. Cardiology plans to follow up with the patient in 6 weeks for cardiac catheterization. At that time, port placement will be considered for long-term transfusion needs. The most recent follow-up liver ultrasound was obtained during this hospitalization as well, and interpreted as multiple hypoechoic foci with an overall interval improvement when compared to prior studies. At the time of discharge, the patient's vitals were as follows: heart rate of 108, blood pressure 97/75, temp of 98.8, and O2 sat 98%, and no oxygen requirement. The most recent transfusion was given during this stay on 4/14, with labs at the time of discharge as follows: a hemoglobin of 12.4, hematocrit of 36.8, white blood cell count of 16.19, an ANC of 95/70, MCV of 74.3, and reticulocyte count of 6.7. Creatinine was 0.24 with a total bilirubin of 0.8. The most recent hemoglobin electrophoresis was obtained post-transfusion with HbF of 2.9, HbA1 32.3, HbA2 2.7, HbS of 30.5, and an HbC of 31.6. Propranolol was discontinued at the time of discharge, given the patient has completed nearly 12 full months of therapy for the hemangiomas, which is considered adequate. We expect that hemangiomas will continue to improve over time as most complete regression by 5 to 7 years old. The patient continued on amlodipine, cetirizine, famotidine, Flovent, and sildenafil at the time of discharge. Pulmonology suspects a concurrent asthma diagnosis, and she is taking ipratropium and albuterol inhalers as well, and was discharged with a prednisolone taper and course of Augmentin. The patient continues to exhibit multiple risk factors for and possible causes of pulmonary hypertension. Infantile hepatic hemangiomas have been associated with high output cardiac failure and pulmonary hypertension. However, despite the decrease in size of her hemangiomas, there's ongoing evidence of right ventricular hypertrophy, atrial enlargement on echocardiogram. As we discussed before, pressures could not be estimated due to the trivial TR jet velocity, and we are awaiting cardiac catheterization for more assessment. Second, this patient has developed multiple episodes of acute chest syndrome with a total of 4 hospitalizations. Could these recurrent events be contributing to the process? Third, the patient appears to have a higher baseline hemolysis when compared to other patients with hemoglobin SC disease, as she has received 14 transfusions thus far. Hemolysis is known to be a factor in the development of pulmonary hypertension in hemoglobin SS disease, but data in patients with hemoglobin SC disease is limited. And finally, this patient has chronic lung disease from bronchopulmonary dysplasia, which could be contributing to the process as well. Given her complex history and multiple medical conditions, the exact underlying cause of the pulmonary hypertension is not clear, but likely multifactorial. Thank you.
Thank you. Great job, Cassidy. Thank you for presenting on our behalf. And so it's open for discussion. We clearly are facing a unique situation of a patient with hemoglobin SC disease, with having such a severe clinical course. Obviously, the infantile hemangiomas were so extensive in the liver, probably contributed to high output cardiac failure and pulmonary hypertension. But we know from our pulmonologists that even NICU babies who have had a significant BPD can have early onset pulmonary hypertension, and that compounded by multiple acute chest syndrome. And also this child's baseline hemoglobins have been hard to determine because of the number of transfusions the child has received. But the lowest hemoglobin can go as low as to the low 7s, for a hemoglobin SC disease. That's a little bit on the unusual side. So very unusual presentation we thought we will share with you and get your thoughts. Is this a candidate? Would you consider this child is only 21 months old to put on exchange transfusion to protect further injury to the lung with the recurrent acute chest? We will consider hydroxyurea, but just want to pick your brain to see what best treatment we can offer to this family.
Ashok, this is Elna. Question, did you guys use sirolimus in this kid?
Sirolimus, no, we did not use propranolol. Remember, sirolimus is more for vascular other vascular tumors
Abnormalities.
like a caposiform hemangioendothelioma or a caposiform lymphangiomatosis. So those type of vascular tumors, sirolimus has been shown to be effective. But just infantile hemangiomas, propranolol will do the job. You will see significant improvement with propranolol alone. And we chose to stop it because most people stop it around 18 months of age, where the maximum progression of these hemangiomas have occurred. Now, after that, they slowly regress over, as Cassidy mentioned, over 5 to 7 years of age. So, and also with propranolol, especially given this child needs, albuterol and other having a beta blocker in place, you'll sort of defeat the purpose, right? You won't get the best benefit of using albuterol and beta agonists in a setting of beta blocker. So there was another reason to stop it, so the child can get maximum benefit from. The prednisone is currently being tapered, but inhaled steroids will start once the prednisone dose is significantly lowered. So please share your thoughts, what you would do for your patient in your center as a long-term treatment.
Again, Cassidy, fantastic job. And, you did a great job. So we hope you continue down a sickle cell hematology pathway. But yeah, that was a very impressive presentation. I guess, that's what, without great evidence, I know at UAB, we frequently will go to more aggressive transfusion in patients, especially if this patient who's going to be, you said it's still on oral steroid?
Yes.
Yeah, so that's a question. For some of our SC kids, we'll just target a 15% S, 15% C, just, with no data to support that, 30% ratio versus 70% A, especially while he's in this acute phase of being on steroids and being ill. So that'd be one. And I think hydroxy would be fine too, but that's something maybe being a little bit more aggressive. I guess the question is, right, will you, what access would you have for pheresis versus a whole bunch of just, partial exchanges to get that S, a little bit lower, or at least get the A to 70%. I mean, would other people,
if it depends on what I'm treating, I don't think that you necessarily need to get people's hemoglobin S down to 30 or abnormal hemoglobin percentage down to less than 30% if you're trying to prevent steroid complications. I'm not sure we know, but I agree that chronic corticosteroids lead to a lot of complications in people with sickle cell disease that are sickle cell patients.
So let me clarify, sorry, that this time the steroids was mainly for asthma. This will be a 2-week course. This child has not been on steroid dependency. Will be on inhaled steroids. So child went home, by the way, and already down to, I think, 1.5 per kilo from 2 per kilo. And we will taper it off in 2 weeks. So 2 to 3 weeks. So clearly it is not a steroid dependent state, but we are worried about the frequent occurrence of acute chest syndrome and persistent pulmonary hypertension.
So I think for pulmonary hypertension, we don't know what to do as far as transfusion. There's the CARE study in adults looking at red cell exchange versus best standard of care, whatever the investigator wants, to try to decide whether red cell exchange helps. I do think that keeping people's hemoglobin higher and people's hemoglobin S lower helps with the nitric oxide driven pulmonary hypertension that we can see in people with sickle cell disease and some of the cardiac dysfunction. But most of the data is in adults, not in young children. And for acute chest syndrome in someone who has asthma, I think that really aggressive asthma treatment is also very valuable, and that may allow you to get away with less treatment. But if you have the pulmonary hypertension reason to do it, I like the idea of trying to keep people's percent S probably less than 30.
You.
This is Bahipu here. I think given how sick this child was and this frequent acute chest syndrome, at least do a couple of months of chronic transfusions would certainly help. I don't think that it will cause more harm than good. Even if you can get the even 50%, it's better than having no aid. But I would, if I were treating, I would probably put them on chronic transfusions for a while.
That's what we're hoping to do. We have not exchanged transfuse somebody like a 21-month-old, and plus she's got poor peripheral access. So we have been very successful in doing single needle exchange with our Vortex sports. So we will try, but we're talking to Terumo, like what is the youngest child they have done with in terms of single needle exchange. So that is something we're exploring, but that's what I was thinking of also, chronic simple transfusion for a period of time with chelation therapy till we can get this child on long-term exchange.
Anybody with additional comments? And then about your SP with hemolysis, and JJ, going back to you, I guess, you were on, right? You were on the ASH CNS guidelines.
I was on the pain guideline, not on the.
All right. So you know that, because my question would be that, when you look at the sickle cell guidelines for CNS, they do make that, statement that you should be doing, for example, TCD screens on all SS or SC patients with, hemolysis in the range of, sickle cell patients. And right, that's what you're saying.
Yeah. I don't think it actually is SC. I think it specifically says S other, like other compound.
Oh, other than SC who have evidence of
similar
hemolysis.
severity. Yeah. So
okay.
I think the SOs and the S, like people with SOSD. I have one person with S beta plus with significant hemolysis, high retic, that has a more typical Mediterranean mutation as opposed to African mutation in their beta globin gene.
Okay.
That I did do some TCDs on. So people like that is what I think of.
But someone like this, right, who has SP with severe hemolysis, is that, do we think that, going back to Dr. Rod, is that driven by, this intrinsic issue within this patient, or is this a phenotype of extreme hemolysis?
Yeah, is it from the sickle cell or is it from the vascular out?
Right.
The vascular malformation. Does it matter? I mean, if it
matter in the terms of, like we're talking about,
if it's intravascular, does it matter? I mean, I don't know. I don't think any of us know the answer. But I think intravascular hemolysis is a big part of the problem. And then sickle cell is, of course, increased cell adhesion, other things that might contribute to some of the mechanisms of increased pulmonary pressures that aren't driven. I mean, might be driven indirectly by hemolysis. I think that it depends on how much hemolysis you have and what it does to your nitric oxide biology.
Thank you for all those wonderful thoughts. So we will keep you posted about follow-up, but that's the plan we are envisioning is the transfusion route for now. And we hope we have done a good job treating the infantile hemangioma, that they will not get any bigger.
And for your other question, would people do dual therapy with hydroxyurea? Right, that was your other question.
Yeah. What's
Anybody
the role of hydroxyurea in this patient? Anybody would use oxybrita in this patient?
I personally would not. I don't know that we have information to say what oxybrita would do in a situation like this. Good, it may help with the parameters of hemolysis and all of that. But what is coming from hemangioma and not would the oxybrita have an effect there? I don't think that we know. And I think with the child being this sick and have I would go with a safer route of doing transfusions until we see this child much more stable before we would try other things. But now I would not do that now.
Yeah, it's not indicated for this age group also because this child is 21 months old. So, but I just threw that as a discussion point.
Yeah, and like you said, you may have you may have difficulties in terms of maintaining, again, we can debate not knowing what an appropriate S to A ratio is in an SC patient. But again, without having good vascular access, it also may limit some of your transfusion medicine, which may be superior to Oxbryta.
Yeah.
All right.
Thank you all.
Thank you. All right, and now we have invited speaker, Dr. Mclemore. We're excited to hear from you, and we appreciate you being a part of the Sickle Cell Research Meeting.
All right. Let me share my screen here. There. See that? Okay.
Yep. Thank you.
All right. This actually will be briefer than I expected to be after I did a delve into the literature. But this topic, I was kind of trying to think of something to talk about, and we recently had 2 cases of retinal artery occlusion, central retinal artery occlusion. Well, one central and one branch retinal, and figured it would be rather topical. But I'm always reminded of the fact that this is a paper from 1956 where Vernon Ingram described the exact amino acid substitution that leads to sickle hemoglobin. But despite this being done in 1956, it's amazing how much we don't know, even to this date. So the first case was a 17-year-old who actually we saw not too long ago had a past history of non-painful loss of vision in his left eye. Optos saw him had central retinal artery occlusion, history of moya and stroke in the past with irregular compliance with prior exchange due to many reasons, mostly social. He had emergent exchange. He had some improvement with vision over time and irregular compliance to exchange since that time. Has not had further stroke nor a second episode of this in the contralateral eye or decreased vision, further deep loss of vision in that eye. More recently, we had 2 other cases, one that I'm not going to show today, but another one that was really rather disturbing. Young 20-year-old, history of sickle SS, had a history of abnormal TCD, was on chronic exchange at one point in time, and then transitioned to hydria. Came in with painless loss of vision in his left eye, was found to have a branch retinal artery occlusion OS. He was exchanged. We had my colleague, Dr. Fasano, had extensive discussions with him. He declined further transfusion therapy, and then 3 months later had a branch retinal artery occlusion in the contralateral eye. He's now on chronic exchange. He's got some evidence of increased intraocular pressures and neovascularization, and I forget which of the eyes, but one of the eyes. He's got central vision loss in the left eye, minimal in the right eye. And then another patient I recently saw had central retinal artery occlusion 7 years ago, treated initially with simple transfusions as he had a low hemoglobin, has had variable compliance with follow-up since that time, but he's had no further episodes despite no real disease modifying agents, including hydroxyurea. He's got decreased vision on the affected side, but so you can see these are, to my mind, almost kind of all over the place as far as both a little bit on presentation, but also on treatment and what was done subsequent to the initial event. And it's really unclear, looking through the literature, any guidance. Just real quickly on anatomy, for those of us who are anatomically challenged, you have your internal carotid, the ophthalmic artery, and then the central retinal artery, shown here, and then your branch retinal arteries. With occlusion, you get this pale area here where the central retinal artery comes in perfusion, this cherry red spot, which is the macula, which gets blood flow from alternative source. Normally, or not normally, in non-sickle cell, retinal artery occlusion is often due to arteriosclerosis, embolic disease, hypercoagulable states, inflammatory disease such as vasculitides, also some lipid disorders, metabolic disorders, and a whole host of others. With sickle cell, there's not a lot of data, and there's no clear guidance, and I found very little on long-term sequelae or recurrence, and there's even less clear who's at risk. One data, which interestingly enough has only been published in abstract, which is data culled from the Cooperative Study of Sickle Cell Disease, showed a fairly low incidence here, 0.02 per 100 patient years. Now, the caveat with over 4,000 patients, median of 5 follow-ups, they only had 9 events, which anecdotally to me seems low. We seem to see 1 of these cases per year. That might just be with our large population that we see, but it does seem a bit low. In this study, there was a slight female predominance. The only really thing that stood out was that people who had retinal artery occlusion were more likely to have a past history of large arterial occlusive disease, such as like bone infarct, stroke, so forth. Stroke itself was increased, but not statistically. And one thing I noticed more recently, and it probably was just coincidence, is that the majority of our patients who I've seen recently tended to have higher hematocrits or hemoglobin values. But in this study, it wasn't, nothing seemed to sort out. This is just a case series from 2008, which they described 3 patients and then went through the literature showing various cases, and what you see subsequent to this are all just case series or review articles. Once again, there's somewhat variable here as far as bilateral involvement. Majority of people were treated initially with exchange, but not all, and even some of those not exchanged up front had recovery. And also somewhat variable is long-term care. I see various people using aspirin, although the rationale behind that's not entirely clear. Some are placed on chronic transfusion therapy. And as in some of the patients we've seen, there's been no therapy at all. So I think there's a lot of questions here. I think a lot of this argues for, once again, some type of large database and follow-up with patients. Initial treatment, we we always prefer to exchange these patients when they, and have exchanged them, with the exception of when there's low hemoglobin, and we'll just proceed with simple transfusion. We've not pursued additional workups as far as looking for other underlying causes, such as hypercoagulable workups. Long-term sequelae, not known. One of our patients is starting to have retinopathy, and Elevated intraocular pressures, once again, is this, we'll see where this goes. Recurrence rates are unknown. Anecdotally, talking with some other providers, most have argued for long-term transfusion therapy, preferably exchange. But clearly, we've seen people who were not maintained on long-term transfusion therapy who have had neither recurrent events and have maintained their stable vision. And I will stop there and see if anybody has any comments. I'm open to them.
Thank you for the presentation. Just from what you have mentioned so far, it's more common in adults, right? You don't see
Yes.
them often in children, and no definite risk factors that you have come up with that can
No.
cause it. And I know that in
I was rather disappointed in the literature.
yeah, but let me ask you this: in non-sickle retinal artery occlusion, has anybody tried like TPA or any of those things to try to bust the clot?
Yes,
low dose system.
yes, it has been used.
And what's the success rate?
I can't comment on that because I didn't delve into it too far.
Would anybody use it in sickle cell patients, TPA, with a sudden onset of retinal artery occlusion? I know
I saw a case report or two, and the patient got better, but several things were done at once, including, aggressive hydration. So it's always rather difficult to know what to make of that.
Hey, Morgan, it's interesting. I think going back to that case series, I think they were mainly SS, right?
Yes, yes.
I don't recall ever having or seeing any SC patients.
I found one case report of an SC patient, and in the report, they mentioned that it does occur in SC, but they did not provide proof. We have not, anecdotally, I cannot remember an SC patient ever having this, other than there is a patient who claims she has SC, who claims she has retinal artery occlusion, but has neither, who keeps showing up at our hospitals.
I have a question. So we had a recent diagnosis of this, I think, but
The globe to reduce the pressures and also consider intraretinal artery like intraretinal artery TPA, like super selective TPA. Is that something that you came across?
No.
Go ahead.
yeah, okay. I was just wondering, is the diagnosis made by the ophthalmologist primarily, or is it more a clinical gastrouche? Because our patient, the ophthalmologist said they didn't see anything, but because she was describing symptoms that were very similar to it, they went ahead and exchanged her. So I was just wondering, is it truly?
We rely on the ophthalmologist.
Okay.
We're pretty fortunate that we can we've never had a problem getting emergent ophthalmologic evaluation.
Okay.
And if you've seen a fluorescein angiography, typically they'll do fluorescein angiography emergently.
Yes.
And if it's stellar. I mean, it's absolutely beautiful, but you get the fluorescein angiography and they're just these areas that are not perfused at all.
Yeah. We're pretty fortunate that we have really good ophthalmologic support.
Yeah, I mean, Morgan, you showed that picture initially. I mean, you have to not see the perfusion through the main retinal artery or one of the branches. It's mainly driven by ophthalmology.
Yeah. If I always try to think if I'm somewhere that has less resources and, if I had somebody come in and say they had, sudden loss of vision, known sickle cell, I would probably exchange them. It's me, but I've always kind of I always try and think of these situations if I'm somewhere where I'm not as fortunate to have these resources, but I think you could make an argument for that, Joy.
Yeah, I don't think, I have to look into our resources for sure, but her first experience happened in November, and then she came in about a month ago saying the same thing. They didn't even consult ophthalmology. So I was just wondering, but I kind of agree with you guys. I'm gonna go talk to my ophthalmology team and see if we can have a good plan.
Make sure she has sickle cell disease, because we have a patient that's doing that, not
Yeah,
having sickle cell.
no, she has that. I'm over that hurdle. Yeah, definitely has it.
No, there is a person who's circulates both Alabama and
Grady, Atlanta.
yeah, in Atlanta, who claims that she has sudden loss of vision in her eye and has SC disease.
I think we talked about her before.
Yeah, she used the ID of somebody from Birmingham, a patient of y'all's from when you were in Birmingham.
Yeah.
So just an interesting thought JJ presented about using intraarterial TPA, but the experience for some ophthalmologists who are especially also retinoblastoma specialists, they can do intraarterial melphalan, for some of those patients. So, but not everybody is trained to do that. So we used to have one ophthalmologist who now moved to Phoenix, so we don't have a retinoblastoma person who can do intraarterial therapy. But not all ophthalmologists can do that. So that would be a challenge for centers.
Do you think that this is an embolic phenomenon, or it's like in situ thrombosis within the retinal artery? Because I was thinking if like having a PFO or ASD or something that's causing some of the thrombi from the line or somewhere else showing into the eye can be a triggering factor.
I think it's just basal occlusion.
So it's like in situ sickling within the.
Yeah.
So again, I'm trying to look up the retinal vasculature, since I apologize for not knowing that well. So, why don't we see more retinal venous issues then? You'd like to think that if, again, a sickling, as it goes through, this vasculature here, shouldn't we also see, venous occlusion if it's just traditional,
I mean,
give up oxygen sickling sort of thought process?
right, but that's an interesting question. Why don't we see more venous issues? Period.
Out of curiosity, did we get a D dimer on any of those patients, and was it significantly elevated? I know in sickle cell they may even be elevated at baseline, but was a D dimer significantly elevated?
No, we did not, and we've tried to discourage people from getting D dimers because to prevent patients getting 5 CTP protocols a year.
Yeah, I think back to Jeff's point about the venous versus arterial event. That's why I asked about, could this be an embolic phenomenon rather than in situ sickling? I think there are a couple of points. One is there is a growing evidence that DVT, like venous kind of thing, will increase the risk of pulmonary hypertension in patients with sickle cell disease. So there is some association between the two. And the second thing we found, like we have few patients with pulmonary hypertension and PFO who develop more stroke kind of events because of embolic events rather than in situ sickling or thrombosis. So that's why I was asking about, is there an association between any intercardiac defect or having a line, central line, and those events or not?
All right, well, I think we have our next case series, multi-center case series for so we can improve the literature here. So
no, I think it clearly tries for this, and I also am relatively, I think long-term sequela are, it's just, it's not there. We don't know.
All right. Well, thank you everybody for your time, and we'll give you back your 18 minutes. Use it well. So good seeing you. We'll see you again in the next echo.
All right.
Thank you.
Thank you.